Welcome, everybody. This is going to be your orientation to integration seminar. I want to talk to you a little bit about what we're going to do in this rotation, and I'm super excited to give you guys this information so that we can get started right away on the first day. So let's talk a little bit about what integration seminar is. This is a simulated clinical environment where you are allowed to take on a variety of roles that are going to help facilitate your understanding and appreciation for a multi-member team of patient care. The setting is considered a safe learning environment for the student. In this setting, the patients can't actually become harmed if you do not provide adequate care, but the student can learn from the situation by being enabled to think on your feet and make critical decisions as a nurse. Now, please don't confuse the term safe learning environment to mean that you're free to just make mistakes, and even if they would be detrimental to the patient in a real setting, they're not looked at as being serious. That is not the case. The safe learning environment just basically is the fostering a positive relationship between yourself and myself as the patient and the healthcare team. Meaning that you are going to make mistakes, and we know that, and you're not physically harming a patient. However, if you don't take this seriously, we do know that those behaviors tend to repeat themselves in real environments, and we're trying to avoid those situations from happening in the real world. It is a learning environment. It is safe. The faculty will never jump on you in front of your peers and fuss you and those kind of things. So um, there's no reason to fear being verbally attacked or anything of that nature in an environment such as this simulation. If you would like further clarification on that, I'll be happy to talk a little bit more about it on the day one of orientation. So students can make mistakes and learn from those mistakes without the fear of harming an actual patient or fear of faculty criticizing, belittling, or being negatively confronting them in front of their peers. It's our belief that integration is one of the safest methods to provide the graduating seniors a real life situation that you're going to be soon faced with and allow you to demonstrate your competencies in clinical judgment, communication, nursing roles, and professionalism. With continuous feedback and observing how others care for patients, students are provided an opportunity to create good habits and identify areas where your current practice could and should be improved. These opportunities allow the faculty to observe the student one on one and see the students' abilities to provide constructive feedback and a formative type of evaluation daily to enhance the learning of the students. This clinical rotation also has a summative evaluation or a high stakes evaluation component. So we do anticipate that the students will have some degree of anxiety and nerves. It's always that case when you know you're being evaluated. So this is not just like coming to pretend and play house. This is a real clinical experience, and you are being evaluated for your ability to provide safe care and make sure that you're maintaining or showing competency in those safe behaviors. So your yes no behaviors that are on the long evaluation tool that's posted on Moodle, you need to take a look at that so that you know exactly what those things are. Um, we don't expect you to make the right decisions all the times, but things that are safe patient care, like med administration, safety regarding the patient exiting the room, OSHA, all of the things that you've learned from day one do count in your evaluation. Hand hygiene, just trying to think, bed rails, that kind of stuff when you're exiting the room. We do not expect you to be perfect or make the right decision all the time, but we do expect you to be safe and always have a rationale for what you do. Please note, we are only evaluating you on knowledge that you have already gained prior to this semester and not on any new content. We are evaluating your consistency in regards to delivering safety measures, clinical judgment, and communication, ability to maintain sterile techniques, roles, active participation in all of the cases that we do, and professionalism. Those are the things that we are evaluating you on a daily basis. So some of the learning objectives for integration seminar are listed on these next two slides, and I want you to kind of take a look at them and understand them, because these are the things that you're expected to do on a daily basis. I expect that you should have some questions on these next two slides on day one. So jot your questions now if you're not sure what we mean by these objectives. Let me just reiterate and say that not all of the objectives are going to be met on one day. We plan for you to meet these on multiple days, but by the end of the 6 days, you should have met all of them. A little bit about the schedule or the schedules. The schedules are going to be posted on the course site under the heading Integrated Seminar Clinical Documents. You're going to find a daily schedule of events. That schedule is going to give you the information regarding how each day will play out, when your breaks are due, those kind of things. Be sure that you review this prior to the first day, because the first clinical day begins earlier than any of the other ones. We start at 7:30 a.m. So if you are there if you don't arrive until 7:30, you're going to be considered late. And that will go against professionalism. You will also find a rotational role schedule. This schedule is going to give you like information on what your role particularly will be on each given day. You may have multiple roles on each day. It just depends on our rotation. Your roles will dictate which daily reflection that you're going to complete, and I'll talk a little bit about that. When you're a patient, so on your patient day, generally you're going to be the patient for the entire day, with the exception of day one, because we have began to implement where I have multiple patients. So again, that day is a little bit different, but days 2 through 6, if you were the patient, you were the patient for the entire day. This semester is a little bit different. So if it says that you're the patient just in the afternoon, then you're going to have a role in the morning, either as an observer or a charge nurse or a nurse, and then you would be the patient in the afternoon. And so if that's the case, just bring your change of clothes to change in at lunch. So you do not need to, on your patient day, if you're a patient all day, you do not need to wear your clinical uniform for that day. It's acceptable. It is acceptable to wear your uniform if you wish, but you do not have to. What you do need to wear, generally as a patient, we want you to know up front that you are taking the risk of having whatever you wear become stained with blood or other products, and we want you to be aware of that. You are allowed to wear a long sleeve black shirt or navy shirt. We prefer the dark colors because they may become stained. Long sleeve is preferred because we'll be taping things to you, and we try to avoid taping to your skin if possible. I do not I do not really want you to wear a hoodie or something that's big and bulky. So keep it to a undershirt type of shirt or a long sleeve shirt, but no hoodies, nothing like that. It just gets too hard to get things taped to you appropriately. Wear dark colored spandex or other comfortable type of pants. Again, just based off of taping things. You're welcome to wear shorts, that's fine, but just know that we will be taping things to your body. Dark colored comfortable pants or shorts for guys. Pants are preferred again due to the needing to tape things. You are taking that responsibility on whatever you decide to wear. Please wear clean socks every day, because you will have to take your shoes off to get into the bed, and so everybody doesn't want to see your dirty socks. All other roles need to be dressed in the clinical attire according to the student handbook. We will be checking your appearance every day. Your shoes need to be the correct shoes. Your pants need to be fitting the correct way. Shirts need to be fit in the correct way. Hair needs to be put up. Follow your dress code. So family, again, you're wearing normal clinical attire. Nurse days during the sim, when you're not actively the nurse, then you're usually going to be in some type of observer role. Okay. Nursing roles, you're only going to be the nurse in one of the 3 simulations that we do. So when you're not in your nurse role, you'll be observing and completing the observer documentary forms and sheets. So make sure that you bring those. Oops, went the wrong way. every day. Make sure that you bring writing utensils, pencils preferred. You can bring pens as well. You need your laptop, you need the stethoscope, pen light, and your resources, whether you bring your parent is preferred. There you can, one or two of you can bring the F.A. Davis book if you'd like, appropriate documents that you need from the course site. Um, during our daily prep, you're not allowed to have your phone out, and I'll talk a little bit more about that in a bit. So, required professional appearance. You can read what's on the screen, your responsibility on that. Lab coats and pullovers. Lab coat is preferred when arriving and exiting the building, just as we would have you do at the hospitals. The MACNES nursing pullover may also be worn in the labs when it's cold, but you have to remove it when you're in the nurse, charge nurse, or patient role. If you're just an observer, you're welcome to wear it. But if you're in an active role in the simulation, you cannot wear your pullover or hoodie or anything like that. Hair needs to be put up and off the collar of your uniform. If your hair is long and up in a ponytail, that ponytail should not hang past your shoulders. You need a watch, but cannot be a smartwatch or Apple Watch or anything like that. We will have you take those off. You can have a wedding band on your hand, a band only, stud earrings, no hoops or dangling, those kind of things. No visible body piercings, no tongue piercings or studs. We'll have you remove those things. Clear stud must be worn in the nose if you have a nose piercing. Please check the policy for your attire. Any violation, whether it's the very first one, if you walk into a clinical day and you are violating the dress code, you will be immediately put on contract. If you're already on a contract for the same issue, that could mean that it's an immediate failure for professionalism because you just are disrespecting the environment. Okay, so please be mindful of those things. Personal items and necessary medical devices. Your cell phone is not allowed for use during the lab during a simulation experience. At 8 o'clock, the faculty will instruct you to turn your phone off, place it in airplane mode, and place it in your bag, it will remain until a break or lunch. You can check your phone for missed calls during a scheduled break or a lunch. Otherwise, it should not be out or visible. If I'm caught with my phone, you can read the highlighted page there. You will get a warning will be issued and then a 3-page minimum paper to complete before the next clinical day, and so forth. You have to prepare to be successful. You have to be engaged in your learning opportunities in order to get out of the experience what you really need to get out of it. If you put forth exemplary effort every day during clinical, I promise you, you're going to have a great experience and you're going to come out of this experience grow with a lot of growth, self-growth as a nurse. That does not mean that you're not going to be told that you've done some things wrong. It does not mean that you're going to be perfect. It means that you're going to grow. Okay. Respect yourself as a learner by doing the first 3 things. Respect your peers and your faculty by being on time, not causing drama, not causing a distraction. There's no dumb questions. And so every time somebody asks a question, it's an opportunity for us to learn. One of my big pet peeves, and I will say this only once, if this is violated, it goes against professionalism. In my opinion, this is huge. This is a respect thing. You will address all of your faculty when you're speaking to me about another faculty in the 8th semester, or when you're speaking about me, or whatever, however you're addressing us. You will not call your faculty simply by their last name or their first name. You will need to be addressing them in a respectful manner, like Mr. So-and-so or Miss So-and-so or Dr. So-and-so, Professor So-and-so, etc. Okay? So don't say like Cooley did this or A-Bear did that. I will give you the first warning of who or how, why are we addressing them like that? Because they're not your equals right now. You should be respectful and professional in the way that you are addressing your faculty. So it would be Miss Doherty or Miss Abear or Dr. Johnson or something like that. Self-directed learning or self-motivation, that's a choice that you have to make, and we make it at all times of the day. So we don't allow students to do any kind of video or audio recording or take pictures in the lab. Um, I will take pictures at times just to send you guys for your slideshow at the end, and those pictures will be sent directly to your representative, and they will be asked to delete those pictures after as well. So day one, we've gone to like an 8.5 hour pre-brief orientation that kind of covers being able to see a hands-on experience with all of the simulation equipment that we're going to use. We do our best to get in and perform all of the skills that you will see during our rotation, so that everybody has an opportunity to see what we expect, how we want you to do it, ask any questions, get critiques and feedback, etc. This day one is going to have no evaluation component in regard to your skills and sterility. Professionalism, hands down, is always being evaluated. You should know that. But day one is the day that I'll be interactive with you. I'll be showing you as you go, those kind of things, so that we can all be on the same page when we begin. It's basically a good practice day. You're going to need multiple observation sheets for practice as well. And we'll all be doing medication administration so that you can see what my expectations are for the rotation. The pre-brief. Day one, again, orientation to the simulation room, environment, setup, and equipment. And we'll talk a little bit about team steps prep work. That's what our pre-brief is going to consist of. Days 2 through 6, your pre-brief, you're going to get approximately 30 minutes. It's about 55 minutes to an hour total for the pre-brief, but you're going to get about 30 minutes to work on your actual profile for the case and your prep work for the case. This is independent work, so there's no discussion with peers unless otherwise directed. No phones in your pocket or anywhere on you. They must be put away and turned off. So one thing that you'll see on here is you get about 30 minutes to kind of do your case prep, but then you have about 20, 25 minutes that we will discuss our team steps prep work. Now, just having done this now for a semester or two, I kind of move things around a little bit each day. So like day one, we probably won't talk much about team steps prep, but day two, we'll cover day one and day twos. And you're get a little bit extra time because of that. So be familiar with, again, be flexible. We'll talk a little bit more about what the pre-brief or profile is going to look like the first time that you get one. We'll go over that a little bit more. But just know you're only getting about 30 minutes to kind of look up the information of what you need to do, complete the work that we need you to do, that is graded and reviewed by the faculty. So what do you actually need to know about the simulations? This is probably one of the most important things. Students ask me all the time, what is going on here? How is it different than high fidelity? How is it different than what we did in 7th semester? So standardized patients is what we use. This is what you've used in 7th semester. It is an actually live patient that is going to be, representing the patient in the scenario. Everything is about addressing priorities with us. It's about what the nurse should do first, second, third, etc. in any given situation. The scenario or simulation is ever changing and it adapts to the care that you provide or omit. Teamwork. You should work within your team and remember that a team can be 2 or more people. And in our case, it's a small team of 2, plus the healthcare providers that you'll be talking to on the phone, to deliver safe care, individualized care effectively and efficiently. The team members are present to help get all interventions implemented in a timely manner, as well as promote communication and utilization of resources. The team members are not there to hold your hand and not do everything for you. Each nurse/charge nurse should be able to demonstrate competent care independently. Until you do something on your own, until you make mistakes and reflect on those mistakes and figure out better solutions, you're never going to change or improve or grow as a nurse. A bad nurse thinks that they have all the answers, they think they can do it all on their own, and they don't need to ask any questions. A great nurse takes the initiative to do unfamiliar things on their own, using their best judgment at the time, and recognizes their errors and weaknesses when they need to get help. They're not afraid to make mistakes, but they are afraid that they won't improve. They are not practicing scared or feared or in fear of failure, but they're practicing expecting to make mistakes and hoping that the mistakes that are minor that allow for growth. A good team places the patient's needs above their own, works together towards one goal. A good team communicates with one another and, most importantly, listens. A team is only as strong as its weakest link. A good team leader will build up the weaker members instead of breaking them down and offer support and guidance to the stronger ones. It's important for you guys to recognize who your stronger team members are and who your weaker members are. It's not okay for you to micromanage somebody that because you think they're a little bit weaker than you or they think a little bit slower. We all think and process data at different speeds. So you have to allow people time to think. Don't just jump in and do it for them. I can't stress this slide enough. I'm not going to read this to you, but this is where most students go wrong and miss out. You have all of these resources at any time during a scenario. All you have to do is say, I would like to call whoever you want to be a resource in the team, in the management of your patient. To simulate or not simulate, that is the question. Students will often ask me, well, do you really want me to do this? Or do you really want me to do that? I can't stress how important this slide's going to be. In our simulations, you will open all packages, whether it's swabs or Hibiclens or Betadol or alcohol or fluids, and you will pour and you will use them as you would in a hospital. You will stay in real time. Example, don't tell me, oh, I'm going to clean for 30 seconds. I want you to just do it. Actually do it. Just actually clean for 30 seconds. But I want to know that you're watching your watch, that you know it's 30 seconds. If you say that you would push a medication over 5 minutes or wait 5 minutes before doing something else, do not time lapse. I want you to actually do it over those 5 minutes. I want you to actually wait 5 minutes before doing the next step. If, in fact, the faculty that is evaluating is satisfied in your performance of what you would do and you're actually using your time wisely and doing things like you're supposed to, we might move you along and say, okay, it's been 5 minutes. The student in the simulation should never move along themselves. Touch the hand hygiene bottle every single time that you wish to perform hand hygiene. There is one hand hygiene station at the door of your room, just as it would be in a hospital. And there's gloves at that same station. You cannot remove those from the wall. You cannot remove them and take them with you. They stay where they are. And anytime you need to do hand hygiene, you need to walk over to the hand hygiene station and touch it. Assess the patient as you would in a hospital. You need to recognize that the patient attire, meaning their clothes that they're wearing, the dark top and bottom, that is their skin. There's no need to ever raise up our patient's undergarment, like shirt or pants or shorts or anything like that. That is their skin. Each patient will have a gown on, and in the simulations, if you were going to assess the abdomen, you would need to raise up the gown. Okay, and anything that you would need to see on the patient's skin will be taped to their clothing. Bruises, etc., incisions or sores, things like that. You will actually push IV medication into the PICC line and the central line and into my peripheral line that I have created. You can also withdraw blood from the central lines that I have created. In regard to IV starts, so in the simulation, you have this live patient based off of their situation and what they need. You may say, I need to start an IV. I want you to decide on that particular patient with their arm. Where would you start this IV? Put the tourniquet on the patient if you need to. Go through the steps of looking for an IV. While you're doing those things, I will transfer the IV arm over to the bed into the same position that you have that current patient in, and then you will actually stick that IV arm, simulated arm. Do not talk yourself through an IV start or state out loud every step that you're planning to do. Just do it like you would in a hospital. Talk to your patient. You should be proficient enough to start an IV that you can talk to the patient or family at the same time. Most of the sharps containers will not be within your reach when starting an IV, just as it isn't in the hospital. So our needles are not retractable. You must use good clinical judgment and make safe decisions when placing your needle somewhere other than in the bed with the patient. Okay, do not put it in the bed with the patient. I don't care how tempting it is. If it's an unsafe situation like that, we're going to mark it down. Central line and PICC line dressings. In these skills, you're going to do all of the steps. Do not tell me, I would clean for this, I would do this, I would do that. I do not want to hear it. I want to see it. Just do it. Use the supplies that the hospital provides to you. We will provide you a kit. You are to use that kit as it is because that is what you're expected to do in the hospital. You're not going to like that because you're so used to remaking your own kits to fit your needs. But you cannot open a sterile kit in the hospital and be like, oh, well, I don't like it set up this way. I need to set it up a different way. That is not how it works. You cannot just get a central line kit and then bring in all these extra things that you want to use because you just don't like their kit. You need to use the gloves that are in the kit. You need to use everything that's provided, the mask that's in the kit, etc. Okay? We'll talk more about that on day 1. Trach suction and oxygenation. We have a working suction canister in our rooms. You will have stickers that are labeled 2 through 15, just as you see here, that you can place on the wall to indicate which delivery that you're administering to your patient. You will explain to your patient what you're about to do, adjust your oxygen by placing the sticker, turn on the suction device, and test your suction. Open your kit, remove your gloves, pour your sterile water in, put on your sterile gloves, attach your suction catheter, and suction the trach for real. There will be something inside the trach when you suction, and it will come out. So be prepared for that. The sounds, the noises, smells, all of those things are very realistic. A Foley catheter. You will actually open the betadine pack, or if the patient's allergic, you will open whatever other pack is available, pour over the swabs or use the swabs in the packet, and you will clean the mannequin part for real. You'll actually be touching the mannequin part with these swabs as you would in the hospital. The parts that we use can be cleaned with the betadine. It's perfectly fine. We clean them every day. NG insertion, you will do everything on the patient that is in the bed up to the point of insertion. So you need to measure on your live patient. You need to educate on your live patient. At the very end of all of that, the faculty will then show you the modifications and where to insert the tube. The stomach, so to speak, will be a baby bottle with contents in it, and it will have contents that you do need to pull back. You can give liquid medications and feedings through the NG tube and the PEG tubes, so you need to bring in water and all the supplies that you need to have in your liquid in your med cups. We're not pretending, we're not simulating like, oh, I would pour this or I would pour that. You should actually have liquids to pour into these devices. For wound care, you will pour the necessary solution over the gauze and you will pack the wounds correctly, I hope. Wound care is going to be different for every surgeon and every facility, so you must be able to read your orders and follow your directions that your physician has given you, even if it's not exactly how you were taught. Administering medications. You will have a computer on wheels that will serve as your Pyxis and your electronic health record. Just as you would need to have your vials of medications and packages in the patient's room in the hospital, you also will need to have them in the room here. We do not have a working scanner currently, so every time that you will administer medication, you will do it as though the computer or the scanner is not working, and we must manually verify everything. Your patients will have an armband on. You will have access to the electronic health record with the PHI at the top, so be responsible for closing that out when not being used. It is your responsibility to verify that the patient's health information on the orders, okay, not the dashboard, but the orders, match your patient's armband exactly. Their name, date of birth, and medical record number should match the armband of the patient and the orders of the patient. This does not mean that the patient has to verbally state his or her name to you each and every time, but that you verify that information is accurate every single time. You can visually compare the information for verification. When you ask the patient to state their information, you're also assessing their orientation, and there is no need to have the patient tell you that information 15 to 30 times in your 30-minute encounter. Your job is to ensure that the patient receiving the medication is, in fact, the patient that was ordered to receive the medication. In order to do that, you must look at your orders and the armband at the same time and verify everything in the room. And this is just one basic critical thinking and clinical judgment method of demonstration. Whatever you do in the med room is not going to count. I'm not evaluating it. I'm not seeing it. Everything that you want to be counted for doing safely needs to be done in your patient's room. Basic medication calculations will need to be done without a calculator. If this worries you, then I suggest that you need to access and practice calculations on Moodle. Calculators will be provided for any weight-based medications or gravity medications that are done without a pump. That might be possible for you to get a calculator. When you give medications, at a minimum, you should state the following. Mr. So-and-so, I have your medications. This is in parentheses. This should be done while looking at the orders. You should state the doctor has ordered whatever the medication name is and the milligrams that the medication comes in. So I have whatever amount that you have. It is ordered daily, which is now, and it's ordered via whatever route. I see that you have allergies too, and you should state whatever the patient's allergies are in the computer and ask them, do you have any other allergies that I'm not aware of? Okay, this medication is for tell them what it's for. Or this medication will help too. Why are they getting it? It will start to take effect in about whatever the time frame is. Let me know if you start feeling and insert side effects. At a minimum, I expect this to be done on every single medication that you provide. If you cannot do this, then you are not being safe with medications. Another thing I can't seem to stress enough, I am in sub-Q medications. You have to know your locations and you have to know your hand placements and how to properly administer those things. You're graduating, and the fact that you guys don't know, or most of you don't know, how to give an IM injection properly or where your sub-Q sites are, that is super concerning for me. And that is something that is a responsibility of yours. So I need to know, in order for me to say that you're giving those safely, that you know that information. In the integration seminar, we do not refill our vials. So they may not have anything in them but air. Pulling up the medications into your syringe from the vial is not going to be seen. I'm going to show you exactly how we want you to do that and handle that at orientation. So again, provide education on the major side effects of the drug that pertain to the current situation. Please read the example, because these are some of the things that I see you guys do in the capstone checkoffs. I'll give the example here of, like, say, Solumedrol, right? That's a short-term corticosteroid, but a lot of you guys are given the long-term corticosteroid effects. Like when you go home, you might have this, that, and the other. Poor wound healing. It's gonna. I'm trying to remember some of the stuff that you guys say. Like, don't take this with grapefruit or antacids. None of that even makes sense when I'm giving IV Solumedrol to a patient. Anything that's like don't take it with grapefruit juice or antacids. That's for an oral medication because it messes up with the distribution and absorption. Not if I'm giving an IV. A short-term effect of a glucose corticoid might be that it makes their blood glucose go up. It might make them hot, that kind of stuff. But they're not going to get a Cushingoid appearance with a couple of doses of Solumedrol. So you got to know what you're talking about when you're giving education on these medications. You need to be aware of the onset and peak for medications. Inform the patient of when to expect their medication to begin working and when they should have the greatest effect from medication. This is when they're most likely to experience side effects. So you need to know to go back during that time frame and reassess them. This information is necessary because if you give a medication, you should always know when to reassess and evaluate. If you give regular insulin, for example, to your patient at 11 a.m., and the transporter then comes at noon to bring them for an x-ray or a CT scan, it's going to be important for you to communicate to that other provider that you've given a medication and that it's going to peak while they're downstairs. In this situation, they will know what to look for if the patient starts feeling bad or has some kind of symptoms. This way, if the patient becomes symptomatic, the other department will know why and will know how to treat them. It is your job to implement appropriate nursing interventions that are required before and after and during administration of the medication. You need to demonstrate how fast to push IV medications, and if there's any dilution requirements, then you need to state that. Verbalization of location of all possible IM and sub-Q sites, and be able to demonstrate each site properly. If you can't put your hands in the right place and show me where that medication goes, then I'm not going to say that you gave it safely. Placing oxygen across the forehead. This is going to indicate visually to everyone behind you that the oxygen is in place. We don't want to risk contamination with our nose germs, so we will not be placing the nasal cannula in the patient's nose. This is going to be one time that I will say that we are simulating something, and I will explain and show you further in orientation day 1. Vital signs. Everything that you need to know is pretty much here, so I'm not going to go over it now. Well, if you have any questions, please write them down and I'll address them on the first day. Assessing your patients. What should be expected? Patients will be wearing a gown over their clothes, which is their skin, so you can raise the gown when needed. Each scenario will require some component of assessment to be completed. You should not be conducting a full head-to-toe assessment during each and every scenario. That will not show me that you have the clinical judgment necessary to determine when and where a focused assessment is needed. You will have to use clinical judgment and determine if a full or focused assessment is warranted based on the timing of care, the changing levels of care, and changes in patient condition. If all 3 or 4 nurses that go in a day do a complete head-to-toe assessment that is fully detailed in all the systems, you're wasting time and we will not complete all that we need to complete. These cases are set up to progress through the patient's continuum of care. Example, patient A presents to the ER with acute onset shortness of breath. On arrival, the mother states he has asthma attacks frequently, but this time it's not getting better. This is probably not the time to start worrying about checking the patient's skin in between his toes or worrying about sensation or bowel sounds. This is an emergent respiratory situation, warranting a very focused assessment and thorough respiratory assessment and vital signs. As the situation begins to improve and you uncover more information that could relate to other problems, then you can explore those further. But if the patient can't breathe, then not much else matters that can be fixed. However, if he's admitted and transferred to the ICU or to the floor, whenever he's more stable, then a full detailed head-to-toe assessment probably should be done in that simulation. Shift physical assessments are done at the beginning of each shift. On arrival, if a new admit is a non-emergent and or any change of level of care. From example, ER being transferred to ICU or ICU to the floor or to the floor to the ICU, cath lab to the floor or ICU. Focused assessment should be performed in an emergent and urgent situations, task specific, and acute changes in condition. Being able to decide which assessment to do at different times requires your ability to critically think, make clinical reasoning, and clinical judgments. Do your assessment on the patient. Do not look back at the faculty for any responses because we are watching what you do, how you do it before we give a response. I want to see you place your stethoscope on all appropriate areas. before I will give you any cardiac sounds. I want to also see you auscultate the lung, and I want to see what fields you auscultate before I give you a response. I will wait and watch where and how you assess pulses before I give you the result. If you only assess the right pedal pulse, then you will only be given a response for the right pedal pulse. While assessing the patient, do not look at faculty for information or responses because we are watching and evaluating your techniques of assessment before we give you a response. So the major goal for each simulation, okay, is for the students to do these things. I need you to start recognizing relevant cues that's given in the report and on assessment. I need you to take those cues and analyze them. I need you to intervene appropriately and efficiently. You need to complete the immediate necessary tasks that address the patient's priority issues. If it's not a top priority, then it doesn't need to be addressed at that time. You need to communicate professionally and therapeutically and provide safe, individualized, patient-centered care within the team unit. Probably some of the most important things here. In order for you to learn something different and change your behaviors, you got to step out of your comfort zone and be willing to make mistakes. Here are some things that you need to know up front. Again, not going to read all this to you. It is your responsibility to read through this. Ask me questions on day one if you have any. It is okay to not have all the answers, but be aware of what resources you would utilize if you needed them. A good example of that is students needing to know if medications are compatible to be infused into the same line. It's okay, don't panic if you're not sure, but know what your resources would be to find out. The next couple of slides I feel like are very important for you guys to know your role. I would encourage you to have your printed out copy of this with you during each of your roles as to keep you in line as to what you need to do. You need to formulate a quick plan of tasks that you would like to accomplish within the first 15 minutes. Do not plan too far ahead until you've laid eyes on your patient. You cannot plan for what is going to happen if you do not know what your patient assessment is going to be. If you spend too much time planning ahead, you're going to be wasting time and you're not going to get things done. Things are rarely what you expect. The nurse will be receiving the report and is expected to assume the care of the patient. You will be expected to prioritize the tasks given, delegate appropriately, assess the patient, call the physician with ISBAR appropriately, and demonstrate safe, patient-centered care. A complex skill will be available during each and every scenario. In the simulation, it is the primary nurse's responsibility to complete the priority skill. The complex skills are as followed. Insertion of in and out catheters, which is a straight catheter, or indwelling male and female catheters, central lines and PICC dressing changes, sterile wound care, clean wound care, trach suctioning, IV starts, NG insertion. Other less complex tasks going forward may be, other non-complex skills or tasks may include administering medications. That could be meds that are PO, NG, PEG, IV, IM, sub-Q, blood administration, ostomy care, portacath accesses. You need to be familiarized with all of those different non-complex skills. Complex skills are to be performed only by the nurse. A non-complex skill can be performed by anyone in the scenario. Students need to familiarize yourselves with the proper usage of peripheral IVs, the differences between that and PICC lines and central lines regarding medication administration, how much to flush through those lines, and what type of solutions to flush, what type of syringes to use for a PICC line. If you don't know that, go look it up now. It's better to know those things before you get into the scenario. You'll be less nervous. The scenario is ever changing and it adapts to the care that you provide or omit. Each nurse should perform some type of assessment during your scenario. I've talked about the difference between a full and a focus and when those need to occur. But if you are an RN, a nurse in the scenario, you should be doing some type of assessment at some point in that simulation. A charge nurse should also be assessing, but we'll get to that in just a minute. Each scenario is designed for the nurse, not the charge nurse, to perform some degree of assessment, priorities, complex skill, and at least one medication. So if you're in a nurse role, I will not stop the scenario until you have completed the main things that you need to do. You need to identify what is the priority things in your patient, treat those, manage those, whatever, but you need to at least administer a medication. You need to figure out at some point, the skill may not be the patient's priority, but I'm telling you that at some portion and point in your scenario, there should be a skill that you should be able to perform. Again, it may not be priority. There are other things that you may need to do first. But if you are getting to the end of your time and you have not performed your skill, there is a skill that you should be performing in that simulation. You'll have a charge nurse to use as a resource or an extra support. But if you allow the charge nurse to make all the important decisions, then I only can believe that you don't know what to do and that I can only evaluate you in accordance with that. The charge nurse will not be with you the entire time, just like they will not follow you around in the hospital and hold your hand. They have their own job to do. If at any point in time you feel like you would need to call a rapid response, security, another nurse aide, I want you to just verbalize that out loud. If I feel that it's necessary for the scenario, I will assign someone randomly to act in support of those roles. Do not, when performing skills, do not walk your way through them. Do not talk your way through them. Do it like you would in the hospital, as if you were with a real patient. Now, if you want clues as to what's important in a scenario, I can't stress this enough. Get out of the tunnel vision. Quit trying to make a scenario go like you want it to go. Put the patient at the forefront of care. Make sure that everything that you do is with the intention to save the patient and not yourself. If you listen to what your patient or your family members say, they're giving you clues. If you listen to the report and you interpret it and analyze it, we're giving you clues. But most importantly, you always have to listen to your gut. If something doesn't seem right or doesn't feel right, it probably isn't. Observe. Watch your patient's reactions. Watch your family's reactions. What are they doing? What are they saying? What's your environment telling you? Observe others and their actions, and you are going to learn a lot about your patient and what to do next. The charge nurse role. Your job in a simulation is to be a leader. We are looking for you to demonstrate leadership skills using team steps. You are going to delegate and prioritize when appropriate. We want you to call a huddle when you feel like it's necessary. Your job is to be the leader. I understand that the nurse is the primary nurse for the patient, but we're asking you to be overseeing and supportive. And when you feel like something needs to be discussed, call a huddle. If you feel like you need something delegated, delegate it out. Be a resource for your nurse. As the charge nurse, we want you to administer medication, but we want you to delegate any complex skill to the nurse just for purposes of our clinical so that we can ensure that all the nurses are performing skills and medication administration. You will not always have a big role as a charge nurse because realistically, you are taking care of 30 other patients on the floor and you have 5 other nurses that you need to be overseeing. However, if the patient's condition changes, that it warrants that they're needing extra help, then of course, we expect you to help out more and intervene. You will wait until the nurse calls you for assistance, and then you will need to intervene appropriately to help the patient. You may assist in getting the patient settled into bed initially when they arrive. but you need to allow the nurse to ask the questions, collect data, assess the patient, unless the patient's unstable and warrants a quick and emergent intervention. The assessment from the charge nurse should be focused on the major priority problems only at hand, and if pertinent assessment or administering medications. Gosh, sorry, I can't talk. Make note of any missed collection of data and collect once the nurse has had their opportunity to complete their initial assessment and data collection. Administer medications when necessary, but you need to allow the other nurse to administer at least one medication. You should be supplemental to the nurse in the patient's care. You are not to be the main nurse. You are not to be in the patient's room when a complex skill is being performed unless the faculty does deem it okay based off of patient safety. If you hover over your nurse, then it appears that you don't have faith or confidence in them to perform or complete their task independently. We want to allow everyone the same opportunities to be independent and safe. You are allowed to bring in a forgotten item or supply to each nurse in your scenario only once. After that, you must tell them that you're busy and they must collect those items on their own. We have to learn time management. Patient and the families. The hardest thing that you're going to do is to not give things away. Okay. You're going to know things that everybody else doesn't know. Now, if we see in any point in time that the patient or family is prompting the nurses with anything other than what we've asked you to do, that's grounds for an immediate clinical contract for professionalism and could result in a clinical failure due to a breach of integrity. We expect you, so patients, you're being evaluated on your patient day on your ability to demonstrate knowledge of the condition that we've given you. So if we tell you to be a COPD patient, like I expect you to give me at a minimum shortness of breath, inability to complete sentences. If I tell you to have a pain of 10, I need to see that you're having a pain of 10. At a minimum, you need to have a grimace on your face. You need to be, a little breathing shallow, or, you need to show signs of pain. Okay. If you're sitting there in the bed and like, yeah, my pain's a 10 out of 10, your evaluation for that day on critical thinking and active participation is not going to be satisfactory. Let's see. So you're being evaluated on your ability to demonstrate knowledge of conditions presented in the scenario, ask questions, exhibit symptoms accurately, and respond to medications as directed. Patients will not verbally or non-verbally make nurses aware of mistakes or prompt them. There will be no laughing or snickering. There will be no like, hey, you left the tourniquet on, anything like that. Same goes for the family. We want the family to demonstrate emotions appropriate for the situation. Family members who just simply sit in the chair and we forget that you're there, that will be a professionalism or lack of participation contract. So just know if you get multiple of these contracts, that is grounds for unsatisfactory clinical behavior. As an observer, if I don't know that this semester we will have any, but if you're in an observer only role, and you don't have a role, like you don't have a nursing role or a patient role or a family role or any other role, when you're observing, you should remain attentive to the simulation being presented and observe carefully. You may not talk or comment to the other nurses, charge nurses, or anyone during your observer role. Do not try to prompt a nurse. That is like an immediate dismissal. Document very specific events that happened. Be very descriptive and specific on your notes. I'll give you an example. So document things that the students did well, but be very descriptive and specific. And look at the example below. All students need to bring one folder with pockets and brads on day 1. I will provide you with another folder, but I need you to bring me a folder that has pockets and brads on day 1. I think the rest of the information is on there. All document. Okay, so we'll talk more about daily reflections. It tells you the due time. but all documents about the patient. So anything from the beginning of our day that we write on, I don't care if it's a sticky note, a sheet of paper, a blank paper, your vital sheets, anything and everything that you write on or get in relation to the simulation day cannot leave the lab. Never leaves the lab. Okay? It has to stay in the lab at all times. If I find that a folder or papers are missing, or that I saw, you were taking notes on something and you took it home, that will be a contract the first time. It will be dismissal and unsatisfactory the second time. Your pre-brief submission is my opportunity to determine what you know and how you think when you're not in the stressed situation. Okay? So that is why it's so important to do individualized work. Now, let me clear up some information on clinical evaluations because we've had some students that were not certain or not sure what was going on. During these sims, you're going to get immediate feedback. That is formative evaluation. And that will be kind of on your nursing and charge nurse performance. We do this usually during the debriefing. We point out things that you did well. We point out things that you didn't do well. I'm constantly taking notes of things that are like considered unsafe, like med administration issues, leaving your bed rails up, not doing hand hygiene, not giving a call light, safety things, y'all, OSHA things. So those things are always being evaluated. You're going to get that every day after your simulation. So there should be no question. Like, if you know that you got a bunch of bad reviews, then you should know, like, okay, yeah, you're learning, but you still had a lot of unsafe patient care. That's not okay. If you have 3 or more unsafe things that happen in one simulation, we're going to put you on a contract because that's our way of verbally meeting with you and addressing a situation and saying, hey, look, you in a 30-45 minute case, you had three different events where you were unsafe with your patient. You broke sterile field, you left the bed up, you didn't do your 5 rights. That's becoming a habit. And so we need to have that documented. Now, if you come to us on a contract for those things already, then that one time can be an immediate dismissal because it showed that in the other 3 weeks of simulation, you already were demonstrating poor behaviors and you're not correcting them. Okay. So you need to understand that we do evaluate you guys in this simulation just as any other clinical experience. Faculty are going to give you written feedback. I say weekly. This does not always occur, especially this semester when I have 13 students. But if there's an issue, if I'm having an issue with your performance, I will definitely send you an email or sit down with you and we will have a discussion. Summative evaluations are completed by the faculty on each student and occur at the end of the 3-week rotation. This is done in eValue. The clinical experience will include a 3-week rotation, and you can read all of those things. And upon completion of a 6-week rotation, you're going to receive a final summative evaluation, indicating if you were satisfactory or unsatisfactory throughout the 6 weeks of clinical. Please ask me questions about evaluations because I've been hearing that people are under the assumption that this is just simulation and it's not a big deal. And, that's just not the case. So, disclaimer notice, you're never being evaluated by another student for the purposes of passing or failing. When students are making observation or critiques, they're trying to build their own communication skills and make us all aware of things that we're doing instead of just going through the motions. We want to stimulate the stressors of family members being present, maybe a doctor or somebody watching us. And so you need to review your yes, no behaviors in the evaluation tool that's provided on the Moodle site. Now, these documents of acknowledgement, you need to print these out and bring them with you on day 1, and we will sign them by the end of the day. Last but not least, personal triggers. So I'm not asking you to disclose very personal information that might be something that you don't want to share. However, if you have had a tragic experience or a potential trigger that you know triggers you emotionally, abuse, sexual abuse, physical abuse, a trauma that, something that's happened to a parent or grandparent, a sibling. Guys, I need to know because I'm not trying to put you in a situation that is so uncomfortable that I'm having you busting out in tears the whole time and you can't perform. That's not teaching you anything. It's not teaching me anything. I need to know these up front. I can't guarantee you that we won't have a situation, but I can guarantee that I won't have you in a situation that you're not aware of or uncomfortable with in that term. And it is something that maybe we need to address and talk about before that happens and coping and things like that. So please, please, this is not me trying to be invasive. This is truly, truly me trying to help you and know what these situations are that I need to try to avoid before they happen. So that is pretty much the conclusion of our orientation. I look forward to seeing you guys in clinical on day one. I hope that you have an excellent experience in simulation and that you truly, truly can embrace the experiences that we give and learn and give everything you have to them so that you can learn.